These are my disclosures. So I'll start off with a case that why this concept of lifetime management is important. Why do we need to start thinking about patients, not just about their index procedure, but how are we going to get them to their remainder of their life? This is a patient who's had three valves, a surgical valve, then a sapien, and then a evolute, and still that evolute has degenerated. It's a hemodialysis patient. Each of these valves lasted around 4 to 5 years, and with no peripheral access, another challenge. So this patient still is persistent that, look, each valve is giving me 5 years. I'm inoperable. Like, how do I'm not ready to die. Please get me another few more years. So we ended up doing a redo transcaval for a second evolute, and total 4 valves. He's still doing well, about 4 years out now. When you think of aortic stenosis current paradigm, we're focusing so much on early recognition and assessment of these patients. We're looking at biomarkers, we're looking at LV thickness, we're looking at CT imaging, that is it time. We don't want to miss this aortic stenosis. We're focusing so much on younger patients, asymptomatic. Early TAVR trial will be presented later this year. And just like the moderate aortic stenosis also, hopefully later this year we'll see. And obviously, patients want less invasive treatment, transcatheter aortic valve. When you think about aortic stenosis, goals of treatment, we as a physician, we as a cardiologist, we really want to make a decision that's based on randomized controlled trial. We want guideline-based decision that has long-term data, and we want really a durable prosthesis and a safe procedure. But when you talk to a patient, what do they want? They really want a less invasive procedure. No matter what part of the world you are in, people in general don't want a surgery. They want a safe procedure, they want to feel better, and they want to go home early and carry on with their daily life as fast as they can. And obviously, they don't want to come back to you. So our goals of treatment may be slightly different, but there has to be a mutual understanding from both these parties, and keeping in mind that ultimately patient wins and they're the centerpiece. Now, these goals may be different. For a 104-year-old, the goal may be, I just want to go back and not be short of breath for my remainder of my life. Whereas when you look at a 31-year-old who's 34-week pregnant and is very symptomatic from a failed bioprosthesis, she's not worried about what is my long-term durability. All she wants is, how can I safely deliver my baby and have worry about the valve down the line. This patient was treated with an evolute TAVR only because the gradients were super duper high and she was short of breath just standing, and we felt like she won't be able to complete term. So when you think of lifetime management, it starts really with the index procedure. Index procedure has to be perfect. No mortality, stroke, minimized PVL, pacemaker, all the regular complications, that have to be minimized. And then you start building up that how do I get this patient the best option of coronary access when this patient comes back with an ACS? How do we give them the best hemodynamics? Hopefully that will be durable for rest of their life. And can we set the stage for that future? When this patient comes in 10 years, 15 years, can we set the stage today? Should we do a surgery or a TAVR right now? Should we consider mechanical or a bioprosthesis? And does the choice of the valve matter? This slide shows you mechanical versus biological prosthesis. On the left graph, what you see is that there is a clear mortality benefit if you choose mechanical valve in a very young patient, up to 55. And after that, that benefit of mechanical valve fades away. So less than 55, maybe there is a mortality benefit of mechanical. On the right side, what you're seeing is that blue is mechanical valve and red is biological. Over the last few years, patients don't want mechanical. They are choosing more and more tissue valves that do not want anticoagulation. So those tissue valves are going to degenerate. This graph on the left side, it's a complex graph, but what you're seeing on this left is that TAVR in less than 65-year-old, right? So the guidelines recommend surgery as the option in less than 65, but we're seeing a consistent rise in number of TAVRs in less than 65. So when these 65-year-olds are getting, or 60-year-olds are getting tissue valves and TAVR valves, they will come back in future, and that's why we need to think about this. This is once again just reiterating that if your age at surgery is around 50, there is very high chance, probability of reoperation is very high, which kind of makes sense. This is a paper that we just published, which shows the prediction of bioprosthetic valve failure in the United States, what's going to happen. The green bar is total predicted valve-in-valve. So in 2024, it's starting to see a rise, and you can see it will rapidly rise over the next few years, your valve-in-valve numbers. Majority of them will, right now they are more surgical valves, but in 2028, the TAV-in-TAV will be same as TAV-in-SAV, and after that, we'll be doing a lot more TAV-in-TAVs when these, your TAVRs you're doing right now, when they start coming back. So roughly 15 to 20% of your population in 2035 will be TAV-in-TAV alone. So think of it today, implant the TAVR today, thoughtfully, that will set the stage for a future valve. So when the first intervention, just to think about it, what are the mortality numbers? What are the outcomes, at least in the published literature? When you have a failed surgical valve and you do a reduce TAVR, mortality is 7 to 8%, and valve-in-valve is a little bit safer. TAVR explant, as all of us have seen from these retrospective reports, that very high mortality. And why is that? Is it just because it's a bad surgery, or is it an explant is bad, it's a tougher operation? Does the valve choice matter or not? When you look at what are the predictors of mortality, median time to explant is 13 months. So this is not your typical patient who did great for 10 years and is now coming electively. There is something acute going on with these patients. This is a premature failure of a valve anyways, and about a third of these patients have endocarditis. So this is a very high risk population anyway, so not a surprise that TAVR explant is going to have high mortality. How about TAV-in-TAV? It's more like a valve-in-valve, right? I mean, when you're putting an Evolut in a SAPIEN or vice versa, the outcomes are more like doing a TAV in a SAV. Procedural success is in fact better. The mortality, all-cause mortality, is about the same as a TAV in SAV. So if it's really TAV-in-TAV is safer than an explant, and it's more like just doing a valve-in-valve, so does the first THV make a difference? And I'm going to show you a few slides just to say, think about your first prosthesis choice, right? The supraannular leaflets, they will be deflected higher when you do your second implant. And when they're deflected higher, the cells will all close, so your neoskirt will be higher, right? So that will impact your coronary flow, your ability to engage those coronaries, your ability for the flow to go into those coronaries. This is just showing you that when you deploy a second valve, even the height of deployment of the second valve can change your neoskirt height. On this left panel, you can see if you deploy a SAPIEN very low, the Evolut leaflets will be having a leaflet overhang, and still you can get some blood flow in the coronaries, whereas if you deploy a SAPIEN high, you really have pushed those leaflets out and your neoskirt is higher. Leaflet overhang, yes, you can deploy a valve very low, like on this left image, but how do they affect the second valve leaflets in long term? Are they going to cause any halt issues? We don't know that yet. There is short-term data that seems okay, but we don't have a very long-term data on this leaflet overhang phenomena. Obviously, it makes sense that if you pin the leaflet, your coronary engagement is going to be difficult. So when these patients come back from acute coronary syndrome, it may be hard to engage those coronaries if your neoskirt is very, very high. So I'll skip a couple of these slides just to show this. I think this is an important slide that focus on this right bar diagram, that this is the chances of redo TAVR. Sinus sequestration will be in almost half of Evolut cases. And it makes sense. Supraannular leaflets, when you deflect them up, they'll go to the STJ, they'll block the sinuses. So this is what Sushil was showing you, DASI simulation. This is hopefully the simulation technology will help us select the initial prosthesis. This is a regular aortic stenosis patient. We simulated the first valve, and then we simulated the lifetime management that, okay, if we choose a SAPIEN on the left as a first valve, can we do a TAV-in-TAV? And same way in the column B, you see if we choose a Evolut as the first valve, can we do a second valve safely? Turns out in this patient, no matter what first valve you choose, you can do a TAV in future. So I'm going to leave you with a couple thoughts, provocative scenarios. 55-year-old, what would you do, a SAVR or a tissue valve, a mechanical valve, or even a TAV, or even a TAVR can be considered. We do this in our clinic. We draw their life diagram. We say how many years are you going to go, how many sternotomies you're going to need, and then help the patient decide. 25-year-old, you think no-brainer, mechanical valve, until they say, well, I want to have a kids. So that brings up a different scenario then. So this is typically what we're doing in our clinic, just to let them understand. And no one answer may fit all the patients. They may have to be individualized. So in conclusion, with expansion of TAVR, more patients will need second or third valve intervention in future. No one size will fit all. You'll just have to discuss what the patient priorities are and just address that. And while safe index procedure is absolutely paramount, we have to carefully pick and optimize the first valve to set the stage for future. Thank you.